Jai Hind and a very good morning to Jai Hind and a very good morning to respected Nikhil Srivastava sir, Principal and Dean, all the heads of the department, faculty members, dear students. I, Dr. Suhasini GP, on behalf of Department of Oral Pathology and Microbiology, Subharti Dental College and Hospital, Meerut, welcome you all to today's webinar on the topic Targeting Oral Candidiasis and Overview. As we all know, since last few years, with our esteemed principal sir's efforts and motivation, we have been inviting our alumni as guest speakers to share their views and enlighten our students on various facets of dentistry. And this year, we are coincidentally celebrating 25 years of excellence of our institution with a series of webinars. It is our privilege to have an alumni from the Department of Oral Pathology and Microbiology, Subharti Dental College, from the first MDS 2004 batch on this occasion to enlighten us with her words of wisdom on the topic. Oral candidiasis, commonly known as thrush, is one of the most common fungal infections affecting the oral cavity with multiple manifestations in various age groups. In majority of the individuals, the causative organisms, Candida albicans, does not cause any serious problems. However, for people with weakened immune system, the signs and symptoms may become severe. Some recent studies indicate that the global pandemic of COVID-19 has predisposed a relatively high number of patients to acute respiratory distress syndrome, which carries a high risk to develop superinfections like candidiasis. In order to prevent the prolongation of disease in undiagnosed cases, it is essential that the dental clinician have an understanding of underlying causes, pathogenesis, various clinical manifestations, and treatment of this disease. It is indeed my pleasure to introduce you to our esteemed guest speaker, Dr. Mandeep Kaur ma'am, who is going to elaborate on this topic. We welcome you, ma'am.
Thank you. Can I start?
Yes, ma'am.
Okay. Okay. A very good morning to respected founders of the prestigious institution.
Ma'am, just a second, ma'am.
Okay.
Dr. Mandeep Kaur ma'am is an associate professor in Indira Gandhi Dental College, Jammu, and is the postgraduate of first batch of oral pathology and microbiology from Subharti Dental College and Hospital in the year 2004. She has a very vast UG teaching experience and has been designated as PG co-guide in the year 2020. She has published more than 30 peer-reviewed research papers in national and international journals. She has participated in various national conferences, CDEs, workshops, webinars, and presented more than 10 papers in national conferences. Her research interest over the year has focused on oral cancer and tobacco-related oral lesions, and she has conducted No Tobacco Day awareness programs as well. She has been a regular columnist in Daily Excelsior newspaper, where her focus is on promoting oral health. She has also contributed chapters in textbook and has been an active member of Indian Association of Oral Maxillofacial Pathology and Indian Association of Forensic Odontology. In a nutshell, she is a very dynamic personality with a keen interest in academics, who has excelled in many fields. So without any further ado, let us welcome Dr. Mandeep Kaur ma'am to address the webinar Targeting Oral Candidiasis and Overview. Over to you, ma'am.
Okay, thank you. Good morning, respected founders of the prestigious institution, Vice Chancellor, CEO, the worthy principal, professor and head of the oral pathology, and professor and heads of all the departments. It's indeed an honor and prestigious for me to be a part of this webinar and presenting in front of the dignitaries I owe a lot as I started my journey of a beautiful life after post-graduation. And I also thank my teacher, my mentor, my guide, Dr. Shushmita Saxena, for what I am today is because of her. So, the topic of today's presentation is targeting oral candidiasis and overview. Introduction. Oral candidiasis is the most common mycosis occurring in the human beings. It is an opportunistic infection of the oral cavity which is caused due to overgrowth of a yeast-like fungus, the Candida. There are different variants of Candida in which Candida albicans, tropicalis, and Candida glabrata represent about 80% of the total isolates of the clinical infection. Candida is supposed to be a normal commensals present in the mouth of healthy individuals, but its overgrowth can result in local discomfort and altered taste sensation. It can also form the esophageal growth, which can result in dysphagia, poor nutrition, slow recovery, and prolonged hospital stay. In immunocompromised patients, it can spread through bloodstream or upper GIT tract with significant morbidity and mortality. It has been seen that systemic candidiasis carries a mortality rate of 71 to 79%, respectively. Coming to epidemiology. Oral candidiasis is widely spread among people in different parts of the globe. Unlike other microorganisms, mere presence of Candida is not interpreted as a predictive signal for disease. Its commensal status has been studied by different authors along many years. 54 to 71.4% of healthy individuals may carry such yeast without any symptoms. Although there are high counts of yeast cells in saliva, which may be a suggestive signal of candidiasis, but always it may not occur. In general population, the carriage rates varies from 20 to 75% without any symptoms. Now, incidence of oral candidiasis varies is 45% in neonates. It is 45 to 65% of
Excuse me,
healthy
ma'am.
children,
Excuse me, ma'am.
45% of healthy adults. Hello, can you hear me?
Ma'am, sorry to disturb, ma'am. Ma'am, can you hold the wire, ma'am? There is a disturbance because of the wire movement, ma'am.
Hello?
Yes, ma'am. Now it is
Hello,
fine, ma'am.
yes.
Yes,
You
ma'am. Yes,
heard me
ma'am.
the previous slides?
Yes, ma'am.
You
Yes,
could hear
ma'am.
the
Now
previous.
you can
Oh, okay,
continue.
okay.
Okay,
So,
okay, ma'am.
incidence of okay, thank you. Incidence of oral candidiasis, according to the literature, is 45% in neonates, 45 to 60 in healthy children, 30 to 45 of healthy adults, 50 to 65 of people who wear removable dentures, 65 to 88% in those residing in acute and long-term care facilities, 90% of patients with acute leukemia undergoing chemotherapy, and 95% of patients with HIV infection are likely to develop oral candidiasis. There is a medical maxim relating to age that oral thrush, which is also known as pseudomembranous candidiasis or moniliasis, is common in very young, very old, or the very sick individuals. According to the Center of Disease Control, it is seen in 1 in every 20 babies. 5 to 7% of babies less than 1 month old are also infected with oral candidiasis. It has been also observed that premature babies have got an increased risk of developing this particular infection. There is a common consensus between the pediatrician and pediatric dentist that it can infect the infants up to 2 years of age. Now, studies have also shown that there is low prevalence of candidiasis in 12 to 36 months old babies. Candida carriage is also seen, the percentage of which varies from 23.7 to 89% in early childhood caries, whereas it varies from 7 to 21% in caries-free babies. The main predisposing factors in these cases can be the baby's feeding bottle, infected passive wires, infection at birth, nurse fingers, hospital maternity ward, maternal skin, air, waters, caries, etc. Now, there has also been relationship present between the presence of a removable orthodontic appliance, Candida, and low salivary pH. It has been observed that removable orthodontic appliance can temporarily affect the Candida colonization. However, Candida fungal colonization is also seen in fixed orthodontic appliance. In one study, patients with fixed orthodontic appliance, 60 patients were studied in which candidiasis was found in 15 patients out of those 60 patients. And 14 patients, the age was between 16 and 18 years. Now, another group of people, that is very old people, are also much prone to oral candidiasis because of the compromised health conditions. Also, these people, they wear dentures, there is diminishing of immune status, there is high expression of transforming growth factor beta, there is also low levels of elastase and salivary peroxidase and negative modulating receptor expressions on the salivary neutrophils. Also, the elderly people experience functional impairment in population of circulating T cells. Now, there are common comorbidities associated with such group of people like diabetes, hypertension, dehydration, medicine intake, which can result in the reduction of saliva production, leading to high predisposition to convert these saprophytic yeast into the opportunistic infections. Epidemiological data have shown that 65 to 84.1% of elder denture wearers are definitely likely to harbor Candida. Aquatic surfaces such as also act as a reservoir for the fungal infections. Broken and loosely adapted dentures may likely to cause the attrition-related lesions in which again the fungal infections may develop. Deleterious habit of cigarette smoking is also one of the predisposing factor for oral candidiasis. The cigarette smoking can result in increased oral epithelial keratinization and enhancement of hydrophobicity. Thus, there is higher oral yeast colonization. It has been also observed that constituents of cigarette smoke may increase the fungal virulence attributes. And we all know that complications like Candida leukoplakia is more commonly seen in smokers than non-smokers. Now, there is a universally accepted fact that reduction in salivary flow rate is one of the most important predisposing factor for oral candidiasis. The salivary gland hypofunctioning can be due to enhanced sympathetic drive, age-related dehydration, diabetes, central acting psychoactive agents, drugs acting on sympathetic system. We have cytotoxic drugs, diuretics, opioids, prolonged diarrhea, etc. And this even anxiety, renal failure can lead to reduction in salivary flow rate. And also in Sjogren's syndrome, the reduction in salivary flow rate takes place in 87% of the cases, and radiotherapy involving the head and neck region, 55.2% of the reduction in salivary flow rate takes place will ultimately can lead to oral candidiasis. Now, besides periodontal disease and caries, negligence in oral cleansing habits can also lead to oral candidiasis. And this negligence is seen in particularly some risk group people like elders, drug addicts, hospitalized patients, and terminally ill patients. Educational status, level of incomes, dental visiting frequency, dental conditions, brushing methods, and frequency. All these factors can also be the determinants of oral candida. Positive relationship has also been found between the poor denture hygiene habits and denture-related stomatitis up to 44%. Now, according to Recovery Organization, 40 to 60% of those addicted to drugs face addiction relapse. Low self-esteem of these individuals often lead them to neglect their appearance and oral hygiene. Now, there has been some studies done in commercialized clinics in Madrid, Spain, and Brazil, in which they found that 10.9% of polydrug users presented with angulochulitis, which is a common oral mucosal lesion occurring because of the nutritional deficiency, poor denture hygiene habits, poor oral hygiene, as well as because of the immunosuppression. Now, in one study, it was observed that 69% of of patients who presented with poor oral hygiene, 19.6 presented with oral candidiasis. Oral candidiasis is also seen in advanced cancer cases in 31 to 70% or 83% of patients according to the different studies. Now, molecular methods like DNA fungal fingerprinting, it has revealed that antifungal treatment failed to eradicate the candida. And one more fact that there's no doubt, absolutely no doubt, that the most common predisposing factor of oral candidiasis is the immunosuppressant effect of HIV in AIDS patients. It was observed that before the advent of heart era in 2000 and 2001, oral candidiasis was a common comorbidities occurring in a variable range of 50 to 52% and 94% respectively. And this heart has definitely produced an impressive decline in the prevalence of oral candidiasis with the values as low as 1.87%. Diabetes mellitus is also one of the predisposing factor. According to the literature, 15.1% of insulin-dependent diabetes mellitus and 24% of type 2 diabetes are prone to oral candidiasis. And various predisposing factors in this case can be hyposalivation, impaired local immune response, higher salivary glucose concentration, and also most of the patients are denture wearers. Now, there is also significant higher levels of Candida albicans than other Candida species in positive oral harvesting. And these results are definitely perceptible in both healthy individuals as well as ill individuals. Now, coming to the various principal virulence factors which assist in the survival of the pathogenic Candida. First is adhesion and colonization. Now, it is usually known that prior to any infection, a microorganism has to undergo adhesion and colonization either to the host cell or to an abiotic substance. After initial adhesion, colonization takes place, which can lead to a disease state. There are different factors which influence the Candida adhesion, primarily the adhesion proteins. Now, agglutinin-like sequence, that is ALS proteins, have been identified so far. 8 ALS proteins are known, ALS 1 to 7 and 9, out of which ALS 3 is supposed to be the most important due to vast upregulation during infection and the ability to bind cadrins on the host cells. They also tend to induce endocytosis of the pathogen. There's another protein, hyphoalvol protein, that is hyphal-associated GPI linked protein, addition of which also induces a covalent bond between the hyphae and the host cell. Evidence have shown that the leading roles these proteins play come from the studies using knockout mouse models, which tend to demonstrate the reduced infection in models of systemic candidiasis. As far as the invasive capacity of Candida is concerned, two invasins are known. We have SSA1, which belongs to heat shock protein 70 family, and ALS3, both of which bind to E cadrin on the host cell and induce endocytosis. Now, this Candida glabrata is the one which has got a very low adherence capacity to gingival cells as compared to Candida albicans and tropicalis. And its adhesive property is under the control of the epithelial adhesion family of the genes. Candida glabrata has also supposed to adhere more to dentures at a twofold greater rate, showing that it has probably got a stronger affinity for binding to prosthetic materials. Now, as far as Candida parapillosis addition is concerned, during infection, few studies have undertaken. In this case, 5 ALS genes and 6 PGA30 genes have been identified. So far, Candida tropicalis, it is known to adhere well to human cells as well as the abiotic surfaces. In this case, 3 ALS genes have been identified. But how and if these genes contribute to addition, more investigations or more evidence are required. Now, attachment of these cells, these candida cells, to the host cell cells to the surface is followed by cell division, proliferation, and development of a biofilm. The capacity of some Candida species to form biofilms is classed as a virulence factor, and most of the microorganisms use this mode for growth. The NK structure of a mature biofilm provides protection by preventing the penetration of the host immune factors as well as antifungals into the extracellular matrix. Candida albicans, tropicalis, and glabrata all have the ability to form biofilms. The hyphal production of Candida species is necessary to form the stable 3D structure, which is very much characteristic of a mature biofilm. They say that Candida glabrata is unable to form hyphae, but still it is supposed to be the second to third most recognized species of Candida. And there are also lack of experimental evidence for Candida glabrata biofilms because most of the time it is found in association with other Candidal species. Now, this is a picture depicting the development of a mature biofilm in which there is initial addition, colonization, maturation, and finally dispersion of the cells to form an infection. In case of severely inflamed Dengue stomatitis, Candida glabrata and albicans were co-isolated in 80% of cases. And Candida albicans biofilms tend to support the growth of Candida glabrata and act as a structural integrity. It acts as a scaffold for the structural integrity. Gene expression here is under the control of the transcription factor, and this controls the upregulation and downregulation of their target genes. Six transcription factor has been identified, and they act as a core regulators which are involved in the formation of a biofilms. And studies have shown that deletion of this six transcription factors in vivo mouse model experiments will result in the formation of a defective biofilms. Once the mature biofilms is fully established, yeast cells can then disseminate out to other areas, thus causing infection. So, biofilm is a fundamental mechanism exerted by Candida, which aid their success as a pathogen by providing a protective niche for these organisms to grow, proliferate, and disperse while defending against the potentially devastating results from the immune system. Next virulence factor is filamentation. The genus fungi grow as a several distinct morphologies. Rounded yeast form is the most common form. Candida adheres to the epithelial cells, then the hyphae are formed as a germ tube projection from the original yeast daughter cell forming branches, which are divided by septa into separate fungal units. Pseudohyphae can also be formed by budding from the original yeast cell. And it has been seen that Candida, whether it is present as a hyphae or pseudohyphae form, both can be virulent because of its ability to penetrate into mammalian cells more easily than in the yeast form. Now, studies have also highlighted about the effective infiltration of epithelial cells by filamentous morphology, which is due to the pressure generated by the hyphal tip. The mechanics behind the generation of the pressure by the hyphal tip is not known, is not clear, but the studies have shown that cells should be properly adhered in order to create a pressure. Tip is a site of enzyme secretion and other degrading substance. And it has also been known that penetrative nature of Candida is intrinsic. So organisms have been programmed to infiltrate any surface they come in contact with. Hyphae are also able to penetrate into the silicon material that biofilms are grown on. The directionality of hyphal growth tip is responsive to the surrounding environment, allowing the tip to direct its way around any sort of obstruction. Additionally, thigmotrophism also occur due to the contact sensing of the cells and cause the hyphae to weaken areas of the cell wall. Control over direction directionality is important in the initial stage of adhesion. And Candida albicans mutant of the RSR1 gene, which is involved over the directionality of the hyphal tip and its growth, becomes erratic, and then its invasive abilities they decrease by 50%. Now, these are the key stages which shows the adhesion as well as the tissue penetration. So adhesion followed by the directionality of the hyphal growth, and ultimately there is invasion taking place. Now, once the initial layers of cell is invaded, control over directional growth is no longer required to cause cell damage. Furthermore, filamentous growth takes place, which act as a mechanism to avoid the phagocytosis of the fungi. And thus the hyphal outgrowth takes place within the macrophages, resulting in puncturing and killing of the cells. Candida albicans, which is widely studied, is truly a polymorphic organism taking on yeast, hyphae, and pseudohyphae. Same holds true for Candida dubliniasis. Candida glabrata can only grow as a yeast. Candida peripilosis failed to produce hyphae, and it can produce pseudohyphae known as a giant cells because of its large curved appearance. Candida tropicalis act as a true hyphae. And if there is mutants of Candida albicans, then it lacks the capacity to form hyphae. Now, this is the Candida, which is present in the form of budding yeast, pseudohyphae, and true hyphae. Candida morphology is also influenced by environment. At pH 7, it tends to induce the hyphal growth, and temperatures of 37 degrees centigrade and carbon dioxide, it tends to promote your filamentous growth. So, group of factors for the hyphal growth, including thigmotrophism, is a successful mechanism of infection. Invasion is further optimized by the release of the hydrolytic enzymes from the tip of the hyphae, which weaken the membrane of the cell. Next, virulence factor is hydrolytic enzymes. Damage and penetration of host epithelium is caused by the release of hydrolytic enzymes in addition to the pressure created by the fungal tip, by the hyphal tip. So, various hydrolytic enzymes are secreted. We have protease, phospholipase, and lipase. The secreted aspartyl proteinase, that is SAP. It functions by disrupting the host membrane, allowing the pathogenic invasion. 10 SAP proteins have been identified. SAP 1 to 8 are secreted, whereas 9 and 10 remain bound to the fungal membrane. A positive correlation has also been found between the biofilm formation as well as the SAP expression. Now, SAP 1 to 3 is mainly responsible for the destruction of host epithelium. SAP 5 and 6 induce hyphal formation and invasive candidal infection. SAP 5 is associated with the early aggressive stage of biofilm formation, and SAP 8 is acting as an emerging prominent player in candidal function, which also plays an important role in upregulating the formation of a mature biofilm. Now, studies have shown that Candida peripilosis failed to produce biofilm. No, it produced less complicated biofilms, and gene sequencing is seen in Candida albicans and tropicalis, but not in Candida glabrata. But more evidence is required to investigate their role in virulence. SAP invasion, however, remains controversial in recent mouse model experiments, because some authors have quoted that SAP 1 to 6 are not essential to cause the infection alone. The fast upregulation of these genes in healthy as well as in diseased individuals play a role in candidal pathogenicity. Now, this phospholipase production is found in many candidal species, which is also an important virulence factor. And this hydrolyze the phospholipids into fatty acids and cause damage to the host cell membrane, with potentially exposing the possible adhesion sites. Now, lipase is another virulence factor which causes disruption of the cell membrane via the hydrolysis of triglycerols. Now, typically, lipase genes encoding the lipase can be found in Candida albicans. We have lipase 1 to 8, lipase 8 1 to 10. Lipase 8 so far has been proven to have a role in pathogenicity, whereas lipase 8 mutant, it showed accentuated virulence in the mouse infection model. Another virulence factor is stress response protein. Now, stressful conditions like starvation within the cells takes place, which will tend to induce the heat shock proteins and prevent the protein unfolding and aggregations. 6 heat shock proteins have been discovered within Candida albicans. We have heat shock proteins 90, 60, 104, 78, and 2 members of the HSP70 family, that is SSA1 and SSA2. In Candida albicans, impaired HSP90 functions lead to a temperature-dependent morphological switch from yeast to hyphae. HSP90 is having a protective effect by preventing the transition to a more pathogenic morphology. Conversely, compromise of HSP90 induces a resistance to azole and echinocandins, which are newer antifungal agents, and help in transforming this fungistatic class of drugs into fungicidal. HSP90 has got a role in protection and virulence. So deletion or depletion of HSP90 will result in reduced virulence. HSP60 is the mitochondrial heat shock proteins, function of which is currently unknown. They say that both are involved in regulation of elevated temperatures. HSP104 and 78 are involved in biofilm formation in response to phagocytosis by macrophages. Both SSA1 and 2 are expressed on the surface of yeast and hyphal forms. Mutants of SSA2 have indicated that this protein may be dispensable for virulence, and SSA1, on the other hand, act as an invasive by binding the surface protein and directly damaging the oral epithelium. Next virulence factor is the antifungal resistance. Now, we all know that antifungal therapy is a classic treatment for the management of oral candidiasis, or for that matter, any fungal infections. But effective antifungal is becoming problematic because of resistance. And we also know that prolonged use of these antifungal agents can actually lead to resistance. And this is of a serious concern, especially in immunocompromised individuals. So it is viewed as an important virulence factor. Resistance is an innate mechanism which is acquired by continued exposure to an antifungal agents where target organism was previously susceptible. It has also been observed that 20% of Candida glabrata stains are likely to develop resistance during the therapy. Fluconazole and itraconazole are active against most of the fungal infections. Itraconazole show activity against fluconazole resistant strains. Voriconazole, on the other hand, act on most of the Candida species, whereas Candida tropicalis is supposed to be less susceptible. A group of antifungal drugs, that is azoles, interfere with membrane component ergosterol, which directly target the biosynthesis pathway, and it results in the loss of membrane fluidicity and function, thus halting the cell growth. And low toxicity of these agents will result in the overuse. It will often lead to overuse of these agents in treating the fungal infection, and we know that ultimately it will result in resistance. Now, mutation in ergosterol biosynthesis pathway is mainly associated with resistant with the use of azoles. Polyen's group of antifungal drugs, that is amphotericin B, are highly fungicidal. They directly target the ergosterol membrane component, forming pores, and thus they destabilize the membrane, causing leakage of the cellular contents. Amphotericin B has got the broadest spectrum of antifungal activity against most of the fungal infection. Resistance to polyenes is rare. It is due to mutations in key members of the ergosterol biosynthesis pathway, and thus lead to lowering the antifungal resistance. susceptibility. Echinocardins are newly developed antifungal agents and they are active against Candida albicans, glabrata, and tropicalis. Since this group of agents are relatively new, so more evidence is actually required to investigate their role in resistance. Reduced susceptibility to antifungal agents can be attributed to biofilms as well as its resistance mechanism. Problem of resistance has been overcome with the introduction of new antifungal agents, but these also follow the same pattern like the predecessor. That is, overuse can lead to resistance. So more research is required to find an effective treatment which will block the resistant mechanism while treating the fungal infection. These are the beautiful flowers from the tulip gardens. Now coming to immunology of oral candidiasis. We all know that epithelial surface is a very important component of host immune defense and surveillance because this is the first component that microorganisms come in contact with. Fungal infection starts at the mucosal surface, and innate immune response tend to prevent the spread of infections. Phagocytes, neutrophils, macrophages, dendritic cells, and natural killer cells are the cells of innate immunity. Innate immunity consists of physical barriers such as epithelial cells, and chemical barriers are the antimicrobial substance produced by the epithelial cells, cytokines, and complement system proteins, which play an important role in upregulating the activity of the cells of the immune system. Oral epithelium secrete and effector molecules which defend against the infectious organisms. They mediate an inflammatory immune response by activating the myeloid cells in submucosa, and thus they try to get rid of the invading pathogens. Important clinical relevance of Candida is ability to form biofilms on surface. We know that. This result in changes in immunity, whether local and systemic, and thus leads to disease development. Candida also induce the morphological changes like transition from yeast to hyphae in response to an external stimuli. This complicates the dynamic phenotype characterization of the host immune response against Candida. And virulence factors are also supposed to be crucial in determining the role of opportunistic pathogen against infection. We have discussed about the various virulence factor like dimorphism, adhesion factors, stigmotrophism, secretion of hydrolytic enzymes, etc. Studies have also shown that 90% of patients with acquired HIV infection develop oropharyngeal lesions during the course of therapy. 80% of all fungal infections are caused by Candida. Non-albicans Candida are also pathogenic to humans, and interaction of Candida albicans with macrophage and systemic infections takes place. Little is known about the role of oral mucosa in the regulation of fungal infections. And pathogenic recognition and cell signaling mechanism in oral epithelium also takes place according to the literature. Candida albicans interact with epithelial cells through adhesion, invasion, and thus they cause the induction of the cellular damage. Experimental oral infection can be further divided into three phases. First, we have the attachment phase, invasion phase, and the tissue destruction phase. Candida albicans exist as yeast cell. So adherent yeast cell will rapidly form the germ tubes after they come in contact with the cell. Then the hyphae will penetrate the epithelium. Then the tissue damage will be increased dramatically in the submucosa. First, the hyphal cells will tend to penetrate the superficial layer of the epithelium and then the deep layer. In contrast, epithelial cell control the fungal cell growth as well as the invasion. Now, during colonization of the oral epithelium, Candida albicans suppresses toll-like receptors 4 and does not induce cytokine production. The infection, especially in the predisposed individuals, lead to increased cytokine secretion and tend to recruit polymorphonucleoleucocytes at the site of infection. After recruitment, several cytokines are directly involved in initiating the subsequent polymorphonucleoleucocytes mediated upregulation of this epithelial toll-like receptor 4 through process called the Remedies. process which do not require polymorphonuclear leukocytes infiltration of the mucosal tissue. Finally, the epithelial TLR4 directly protects the oral mucosa from the fungal invasion and injury, possibly by the production of antimicrobial peptides. Now, this is a model showing the toll-like receptors 4 mediated as well as polymorphonuclear independent antifungal defense by oral epithelium. We have two toll-like receptors 2, 4, 6 protecting the oral epithelium. The role of receptor signaling and regulation of the immune response against pathogenic fungi in the oral cavity has also been described in the literature. They say that innate immunity initiate an immune response, and it is supposed to be the first line of defense against the microorganisms, and this also includes leukocytes and epithelial barriers. Interaction between fungi and the host is initiated by the cell-to-cell interactions at the plasma membrane. Different molecules has been thought to be expressed on the walls of fungi. These molecules serve as a molecular patterns. Now, for example, the receptors, there's one receptor that recognize the molecules synthesized by the host. The expression of which indicates the cellular damage is known as DAMP. That is damp associated molecular pattern. We have different receptors. We have toll-like receptors, TLR, we have knot-like receptors, and LR, we have CLR, C-lacting-like receptors. Now, better understanding of cytokines is required to understand its function and also its use in therapy and prophylaxis of fungal infections. These cytokines are the cytokines which are produced are derived from T cells. So two different groups of CD4 T precursor cells are produced. We have Th1, T helper 1, and Th2. Differentiation of CD4 T cells is dependent on the species of Candida and the presence of cytokines. The cytokines induction in induction response, the Th1 cell mediate it protect the dependent on the phagocytes whose cytokines are produced. Most important ones are defense against Candida albicans are interleukin 2, interferon gamma, interleukin 12, and tumor necrotic factor. Now, this Th2 cells produce the cytokine inhibitor, such as TL, interleukin 4 and 10, which are associated with the phagocytes and disable the disease progression. It is argued that genetically determined resistance to infection is correlated with the balance between protective Th1 and non-protecting Th2. But the activation of the innate immune system, they say, is not enough or not sufficient to control the infection alone. There has to be important interaction with the adaptive system. Acquired immunity correlates with the expression of Th1 at the site or the peripheral of the infection. Th2 response is dependent on the patient's health. Upon activation of leukocytes population by the Candida, there is release of pro-inflammatory cytokines such as tumor necrotic factor alpha, interleukin 1 beta, interleukin 6, and interferon gamma. Now, they activate these pro-inflammatory cytokines, they activate macrophages and the neutrophils to phagocytose fungi and release toxic oxygen radicals and the nitrogen, thus eliminating the invading pathogens. So macrophages, neutrophils, endothelial cells, fibroblasts, and T and B lymphocytes all secrete tumor necrotic factor alpha, and they exert multiple biological effects such as cell differentiation, proliferation, apoptosis, cytotoxicity, inflammation, etc. Tumor necrotic factor alpha also induces the production of other cytokines such as interleukin 6 and 1, which may participate in the host response during the course of systemic infection by Candida albicans. The release of tumor necrotic factor alpha by macrophages during the early phase of the inflammatory response to fungus, it attracts and thus activates the neutrophils. Among Th1 cytokines, interferon gamma is a potent activator of phagocytes. It has got a role in cell differentiation, inflammation, interleukin 12, whereas is required for the optimum Th1 development. The production of interleukin 4 is dependent on the amount of fungus which is present at the infection site. And interleukin 10 was found to be the first potent anti-inflammatory activity, and these cells are the main inhibitor of the innate immune response and anti-inflammatory as well as immunoregulatory. Now we will briefly discuss the clinical variants of oral candidiasis. First, we have the acute erythematous candidiasis. Now, acute erythematous candidiasis is a frequent clinical manifestation among AIDS patients. It is an oral mucosal lesion which is often seen in such HIV-infected individuals. And it has been observed that the patients with acute erythematous candidiasis, CD4-CD8 ratio is less than 0.30, and CD4 levels are also less than equal to 200 cells per millimeter. Thus, the presence of acute erythematous candidiasis may act as a marker to diagnose the immune status of HIV-infected individual. But there has been the prevalence of acute erythematous candidiasis has decreased after the advent of heart era. And the percentage of acute erythematous candidiasis in patients undergoing heart varies from 7 to 16%. Some investigators believe that it may represent an end stage in the renal disease patients and type 2 diabetes mellitus, which is of, again, a serious concern in determining the immunological condition in such individuals. Hypopharyngeal lesions were reported in patients under treatment with topical intranasal steroids. Clinically, it is seen as localized erythema, burning sensation, loss of filiform papillae. Most common site is the dorsal surface of the tongue. It can also be seen on palate and buccal mucosa. It is referred to as antibiotic sore mouth because of the prolonged use of antibiotics, which facilitates the overgrowth of Candida albicans. And this is seen on the tongue with erythematous areas along with the papillary atrophy. And in this case, it is often associated with the systemic diseases like iron deficiency anemia and B12 deficiency. Diagnosis is mainly on the basis of clinical findings, but it can be confirmed by the identification of blastospores and pseudohyphae stains smear, which are samples from the lesions. Colonies can be cultured on the Sabrod culture medium. Histological examination is also done to confirm the diagnosis. But some studies have shown that the false negative results in 25% of culture test and 42.5% of the microscopic examination. For this reason, combination of fluorescent staining and observation during a portable fluorescent microscope can be done. Next clinical variant of oral candidiasis is the acute and chronic pseudomembranous candidiasis. Pseudomembranous candidiasis or thrush, as it is popularly known as, is a common clinical variant of oral candidiasis, which was first reported by French pediatrician Francois Valeix in 1838. It can be acute with rapid oral manifestation because of broad spectrum antibiotic exposure, which tend to disrupt the balance in the oral microbiota. Clinically, it is seen in white or yellow plaques, which can be removed by rubbing the mucosa, and on removal, we can see the erythematous and bleeding areas. Common site is buccal mucosa, soft palate, tongue, and lips, and these plaques mainly represent the overgrowth of the yeast on the mucosa and results in epithelial cell T squamation, accumulation of bacteria, keratin, and the necrotic tissue. Chronic infection usually stays for a longer period of time, and it is commonly seen in immunocompromised patients and those undergone some sort of organ transplantation. It is also seen in HIV-infected individuals with endocrine disorders, and who have undergone systematic corticosteroid therapy, chemoradiotherapy, and who are on cytotoxic and xerostomia drugs. Diagnosis is on the basis of clinical findings. It can also be diagnosed by the removal of white plaques, and on removal, we can see the erythematous areas. And in advanced cases, sometimes full oral mucosa can be affected. Some investigators believe that the presence of acute and chronic pseudomembranous candidiasis have been overestimated during the last years. And so, for this reason, it is advised that in immunocompromised patients, a smear stain from gram should be carried out to the differential diagnosis of pseudomembranous candidiasis. candidiasis with yellow and white plaques occurring because of the opportunistic bacteria. Associated symptoms are usually minimal, but patient may complain of some sort of sensitivity, burning, and dysphagia. One interesting factor also has been reported in the literature that the persistence of pseudomembrane can actually result in loss of pseudomembrane. And this is particularly seen on the tongue area with areas of deep appellation and decretinization. So it is said that it's better to highlight the history of the patient and the response to the treatment with antifungal drugs. Investigation or diagnosis can be confirmed by exfoliated cytology, swab culture, imprint culture, and mucosal biopsy. So these are the hyphae which we see in the pseudomembranous candidiasis. This is characterization and infiltration of epithelium with hyphae. Next clinical aspect is the Candida-associated denture stomatitis. Candida-associated denture stomatitis is also predominant fungal infection in the oral cavity. It is encountered in the dentition, tongue, cheeks, palatal mucosa, restorative material, and other prostheses. Candida albicans is the most commonly isolated organism. Candida glabrata tropicalis and paraporosis has been found, but less frequently. There are factors which favor the development of Candida albicans biofilms, such as capability to stick and proliferate through the denture surface and oral mucosal epithelium, and it results in the formation of a complex and heterogeneous bacterial biofilms. Cats has been found in 60 to 65% of the denture wearers, whereas cats is supposed is nothing but a common oral mucosal lesions, which is commonly seen under the removable dentures. In fact, it affects 1 in every 3 complete denture wearers. Local factors like radiation, trauma, complete denture wearers, poor dental hygiene, smoke, etc., results in the formation of biofilms, and systemic factors like diabetes, chemotherapy, hemophilia, immunosuppression can result in the disease development. Sign and symptoms varies from no symptoms, severe pain. Patient may complain of difficulty in swallowing. There may be changes in color, texture of the mucosa, dry mouth is there. Whereas cats is again, as I have told, that it is a erythematous area which is occurring in patients wearing removable dentures. Now, Newton 1962 proposed classification of the disease based on the clinical aspect. We have class 1, punctiform hyperemia, in which hyperemic erythematous diffuse areas are seen in the soft palate involving the minor salivary glands. Class 2, or the diffuse hyperemia, which is the most common form, in which smooth and atrophic mucosa with erythematous aspect under the denture is evident. Class 3, or the granular hyperemia, it is commonly seen in patients wearing dentures with suction chambers. Rough and nodular appearance of the mucosa is seen in the central region of the soft palate. Next, a variant of oral candidiasis is chronic hypoplastic candidiasis. The chronic hypoplastic candidiasis, or Candida leukoplakia, is least common as compared to erythematous and pseudomembranous candidiasis. Local factors such as occlusal trauma or friction in commissural leukoplakias actually causes a breach in the integrity of the oral mucosa and thus an infection. And smoking habits has definitely got a very strong correlation with the commissural leukoplakia. And chronic hypoplastic candidiasis is also seen more in the mouths of smokers than non-smokers. It is not well established whether the invasion by Candida is actually responsible for the development of oral squamous cell carcinoma. Chronic hypoplastic chronic hypoplastic candidiasis is associated with oral cancer, but the role of Candida is still unclear. It is seen in malignancy in 15% of cases. The lesions, especially which are heterogeneous of hypoplastic candidiasis, in which the white plaques are intermingled with erythematous area, have got a more malignant potential. Clinically, it is seen as white patch at the commissural lesions. Common sites are palate and lateral border of the tongue. Lesions are symptomless and resistant to scratching, varying from small, translucent, whitish areas to large opaque plaques. So, apart from sign and symptoms, complete medical history should be taken. Diagnoses are confirmed by laboratory tests from the clinical samples taken from the lesions. And it has been said that oral pharyngeal swab culture may demonstrate Candida, but oral colonization of Candida is more common. Diagnosis can also be done by 10% potassium hydroxide slide preparation, and it is necessary to do the biopsy in this case because not only to diagnose chronic hypoplastic candidiasis, but also to rule out any other white patch or any other dysplastic features or oral cancer. So this is the histopathological site of chronic hypoplastic candidiasis, in which we can see the hyphae infiltrating the epithelium. Next, clinical variant, which has got a correlation with candidiasis, is median rhomboid glossitis. So this is the only case which was seen in the department. So this median rhomboid glossitis is a smooth patch which is seen on the dorsal surface of the tongue in the midline, just anterior to the circumvallate papillae. It is defined as a central papillary atrophy of the tongue. Prevalence is 0.25 to 5.42%. It is usually asymptomatic, but patient may complain of pain, irritation, pruritus. Lesions may be ulcerated, exophytic, or lobulated, and median rhomboid glossitis may be accompanied by contact lesions on palate. And this mainly occurs as a result of prolonged contact between the Candida infected midline, dorsal surface of the tongue, and hard palate. Despite of its relative frequency, etiology is unknown, but it is thought to be developmental in origin, and it is also commonly seen in adults. Some believe that it might represent an end stage of oral candidiasis, similar to papillary hypoplastic candidiasis. Now, some authors have hypothesized the role of oral candida in the development of median rhomboid glossitis because embryologically, traumatic etiology and mixed microbiota tend to favor the development of median rhomboid glossitis. And for this reason, it was observed that topical application of antifungal agents in these patients led to the clinical improvement in some individuals and no improvement in other individuals. Now, correlation between oral candidiasis, oral hairy and HIV infection. Oral candidiasis and oral hairy is the first manifestation of AIDS. It is considered to be the marker of immunosuppression. It can be assigned to one dentist, and oral candidiasis appears to be a superior indicator of immune decline. So it is be observed that the presence of both can be an indicator of low CD4 count and high viral load. Now, few authors have said that joint manifestation of both oral hairy and oral candidiasis is not much reported in the literature, but there are few studies which we have quoted that 36 cases of oral hairy and HIV infected patients with candidiasis were detected in 88% of cases. 4.6% of HIV infected adults of North Carolina had oral hairy and oral candidiasis simultaneously. So it was concluded that low CD4 count and smoking were independent risk factor for joint manifestation. But in one case, the Candida hypha was seen in 8 of each 10 patients with oral hairy in HIV negative patients. So simultaneous presence of oral hairy and oral candidiasis is still an enigma. Oral candidiasis can be a primary disease or secondary because hypha was seen in some and hypha was not seen in other, which is superimposed on oral hairy leukoplakia. Now, clinical correlation between oral candidiasis and oral lichen planus. Candida albicans is also an isolated fungi of oral lichen planus, in which we see the defects of the epithelial cells. Adherence of Candida to oral epithelium is first step in the infection, which enables the yeast to overcome normal flushing mechanism of body secretion. They say that oral Candida may act as a secondary pathogen in lichen planus, which may be a superinfection and leads to increase in signs and symptoms, which are mostly defined as burning sensation or discomfort. Hyperkeratinization is important histopathological feature of oral lichen planus, and this contributes to a predisposition for Candida infection. Candidiasis was seen in 37 to 76.7% of lichen planus cases, and treatment of oral lichen planus with steroids is known to lead to secondary yeast infection, which can further complicate the treatment. Candida albicans, glabrata, and tropicalis were isolated in patients with oral lichen planus. Then in patients with oral lichen planus who have undergone the treatment with topical corticosteroids. Oral candidiasis was also seen in 17.4% of ulcerated cases of lichen planus and 16.4 of non-ulcerated. This genotypic profiling virulence attributes of Candida albicans can determine or have a role in determining the progression and development of the disease. Healthy individuals with oral lichen planus are more prone to have oral colonization of Candida. In this, also Candida albicans was common. Again, oral candidiasis was seen in 72% cases of erosive form and 28 in non-erosive form. So we all know that oral lichen planus is a carcinogenic potential. An infection by Candida fungus is more frequent in patients with oral lichen planus than without it. The potential endogenous nitrosamine metabolism is also observed by Candida albicans, which can be carcinogenic to oral mucosa. So this nitrosamine directly or indirectly cause activation of specific oncogenes. Studies have shown the use of antifungal agents to reduce the potential production of carcinogenic by Candida albicans. But the relationship between the dysplasia and the development of fungal infections is still under investigation. It's not that clear. So again, last association of Candida with linear gingival erythema in HIV-infected subjects. The presence of hyphae or pseudohyphae is a good indication of tissue penetration of Candida in the gingiva. And it is very interesting to know that patients with linear gingival erythema, their they all showed, some of them showed decreased CD4 lymphocytes. 42.9% of HIV positive homosexual men having oral candidiasis had LGE, and 12.7% of the subjects without candidiasis had linear gingival erythema. The American Academy of Periodontology considers linear gingival erythema as a gingival disease of fungal origin. We should take care that if LGE does not respond well to plaque control measures, then antifungal treatment should be initiated immediately. Though there are also a series of studies done on LGE, in which Candida was supposed to be a one of the etiological agent. Subgingival plaque samples were taken in which it was found that 42.3% of Candida was seen in HIV-infected in children, whereas 7.1% of Candida was seen in HIV-negative children. So prevalence of prevalence of Candida is also was also isolated from the periodontal pockets, and which may be due to the high carriage of Candida in the saliva. The serine protease activity, which was produced by the Candida isolated, derived from the linear gingiva lesions in HIV patients was seen. SAP secreted by Candida was also able to cleave the various components of host immune response and extracellular proteins, which tend to facilitate the dissemination of Candida into deep organs, protecting from the host immune response. So histopathological studies, according to the literature on linear gingival erythema lesions, have observed that the Candida is able to penetrate the gingival epithelium. So there are substantial evidence to suggest a strong association between Candida and linear gingival erythema. Finally, briefly, we'll just deal with the treatment of candidiasis. Treatment of Candida or oral candidiasis has found to be efficacious with the advent of newer and known antifungal agents. However, treatment should be the success of treatment is directly correlated with correct diagnosis, identification, correction of etiological factors, and commitment of patients. Antifungal agents definitely will bring relief from the disease, but smoking should be eliminated, oral hygiene should be improved, and disruption of the biofilms consist of an important adjunct factor in the healing process. So antifungal agents, amphotericin B, which is derived from Streptomyces nodosus, Gold and Cleese discovered this macrolide in 1956 and increases the permeability of cell membrane of fungi, results in the loss of cytoplasmic constituent. It is both fungicidal and fungistatic. It can be used as oral solution, mouthwashes, systemic infection IV is given. Nystatin was discovered in 1950s by the New York State Health Laboratory. It was derived from the Streptomyces nodosi culture. It is both fungistatic and fungicidal, and it has got a reduced activity than amphotericin B. It is especially used in immunocompromised patients as prophylactic treatment. It has got a bitter taste, so sucrose and flavoring agents are added to its formulation. It can be used in children and adults as mouthwash, neonates, preterm, lactating children, etc. Imidazole and triazole agents were discovered in 1960. it is capable of inhibiting the transformation of the yeast cells of Candida species in hyphae. Ketoconazole was the first drug which was used for the treatment of systemic candidiasis, and it is used in rare cases of resistance to other candidiasis, to other antifungals. But according to FDA, it cannot be used as a initial therapy for the treatment of oral candidiasis. And if it is used for more than 2 weeks, liver function studies are recommended. It tends to inhibit the production of estradiol and testosterone, and it also causes abnormalities in the menstrual cycle and gynecomastia. Cotrimoxazole is more tolerated by patients. It has got a better taste than Nystatin. Itraconazole is a new synthetic triazole agent. It is less toxic. Fluconazole is very effective medications to the greater specificity of than ketoconazole. It is especially used in immunocompromised and immunosuppressed individuals, and in HMA patients, it is used as a prophylaxis against candidiasis. Posaconazole is available in Europe since 2005. It is approved by FDA 2006. Is it particularly used in oropharyngeal candidiasis, and is used in those patients who are resistant to itraconazole and fluconazole, and it is supposed to be more effective against relapse. Miconazole, it is the first antifungal imidazole derivative. It has got both topical and parenteral indications. Echinocandins, it is a new antifungal class which is approved by FDA, and it works by fermentation of fungus, and in severe cases it is given IV. Caspofungin, it was improved by FDA in 2001. It is used in case of severe fungal infections, and it is used in those patients who are intolerant to amphotericin B. Macafungin was improved in 2005, and anidola fungin has got a high antifungal potential, and it's used in those cases which are resistant to fluconazole, amphotericin B, and echinocandins. So these are the home remedies which can also be used. We can use garlic, apacitar vinegar, baking soda, vinegar, trees oil, cinnamon, salt water, thyme, and other essential oils, which has been approved by the nanis and dadis for the treatment of oral thrush. So conclusion: there is more persistent requirement in the research of newer effective agents, and such as the development of vaccine, and there are various experimental strategies which has been employed, such as accentuated live candida organism, SAP gene family proteins, glycoconjugates like mannins and beta glucans, but clinical trials are still distant versions, distal version. So I can no other answer but make thanks and ever thanks for giving me an opportunity to be presenting at this platform. So I thank you everybody, and please stay safe and stay healthy. Thank you.
Thank you so much, ma'am, for such an informative session. Now, I would like to invite Dr. Nikhil Srivastava, sir, Principal and Dean, Subharti Dental College, to address the audience. Sir, you're not audible, sir. Sir, you're not audible.
No, they can hear us. Bhagwan sir is trying to fix it.
Can you hear me now? Dr. Mandeep, can you hear me?
Good morning, sir.
Okay. Good morning, Jai Hind. Thank you so much
Jai Hind.
for taking out your time, Dr. Mandeep, and
Thank you so much.
enlightening
Thank you
all
so
of
much,
us.
sir, for and
No, thank you very much. I mean, I'm sure that third year and final years who are listening to you must have gained out of your lectures. As already told by Dr. Suhasini, that we are celebrating 25 years of excellence of this
Yes, sir.
particular college in the field of medical education, research, and clinical care. So
Yes, sir.
I think this was the best way to celebrate throughout the year by inviting our own
Thank you,
people
sir.
who have actually
Yes, sir.
witnessed the
Thank you.
progress of this institution right from
Yes.
you came in 2004. So the college was
Yes, sir.
initially, I mean, it was very young college, and now
Yes, sir.
we have developed a lot. Now we are our own university. We are postgraduate
Yes, sir.
recognized institute. We run a lot of courses. So
Yes.
it was really wonderful to listen to you. But then
Thank you so much,
I
sir.
request that your responsibility doesn't end here. As
Yes,
alumni,
sir.
you have to stay connected with your own institute.
Yes, sir.
As you
Yes,
rightly said,
definitely, sir.
as you said that whatever you are today, it is because of your head of the department. So I would
Definitely, sir.
like to add
Definitely, sir.
one thing, that yes,
Yes,
whatever
sir.
you are today, it is because of your institution and your teachers, right?
Definitely, sir. Yes.
So,
Yes, sir. The institution, of course.
so now this is a good time to pay back to your institution with your
Okay, sir.
knowledge, skills, your time, and
Thank you,
enlighten
sir.
all your juniors. They'll be very happy to listen to you. And we
Thank you,
always
sir.
wanted to get all of you here to have a good gathering, but because
Yes,
of
sir.
Corona, we couldn't do this thing. But
Yes,
we are
sir.
still hoping that in months to come, the things will become normal, and then we'll be able to invite all of you. You can see the
Yes, sir.
progress of your own department, your own college, your own colleagues.
Yes,
So
sir.
with these
Thank you,
two
sir.
words, once again, thank you so very much. And I must
It's
appreciate the Department of Oral Pathology, Dr. Vijay Vadhavan and the
yes, sir.
entire team for organizing this particular lecture. And then
Thank you so much,
what we
sir.
have decided, Dr. Mandeep, that every second and fourth Friday from 9 to 10th, we are going to have these lectures throughout the
Okay,
year.
sir.
So,
Yes, sir. Yes, sir.
month-wise, the departments will come and their HODs will come. And I
Okay, sir.
request you and all your colleagues to please join on every second and fourth Friday from 9 to 10.
Okay, sir. Definitely, sir.
All right.
Thank you.
So,
Definitely,
so
sir.
now the last, on behalf of entire college and the Department of Oral Pathology, it is my privilege to present to you a certificate of presentation. This is
Okay, thank
kindly
you, sir.
accepted on behalf of Oral Pathology Department and Subharti Dental College and Hospital.
Thank you so much, sir. Indeed, a pleasure, sir, to be connected with you and the institution. Thank you so much, sir.
Thank you so very much. Thank you. Thank you. Then see you on
Thank you
fourth
so much.
Friday, 9 o'clock.
Yes,
All
sir.
right.
Yes, sir. 9 to 10 second. Yes.
Thank
Thank
you.
you so
Jai
much,
Hind.
sir.
Bye-bye.
Jai Hind. Jai Hind, sir. Thank you.
Thank you, sir. Thank you, ma'am. Ladies and gentlemen, it's my privilege to propose a vote of thanks on behalf of Department of Oral Pathology and Microbiology. Once again, I extend a very hearty vote of thanks to our alumni speaker, Dr. Mandeep Kaur ma'am, for sharing her experience and knowledge. I would like to take this opportunity to express my sincere gratitude to our chief patrons, Dr. Mukti Bhatnagar ma'am and Dr. Atul Krishna sir for their continuous support. I express my deepest gratitude to Dr. Shalya Raj, CEO, Swami Vivekanand Subharti University for the support and guidance provided for this webinar. I'm thankful to our esteemed Vice Chancellor, Dr. V.P. Singh sir, for continuous guidance. My sincere thanks to Dr. Nikhil Srivastava sir, Principal and Dean, Subharti Dental College, for the constant motivation and support in organizing this webinar. Also, I would like to thank Mr. Vishal Singh, Head, Marketing and Communication, Swami Vivekanand Subharti University, for all the technical assistance. Finally, my heartfelt thanks to all the HODs, faculty members, and the students for their keen participation in this webinar. A big thanks to you all. With this, we
Thank you so
conclude
much.
today's webinar. Thank you and Jai Hind.
Thank you so much, the Department of Oral Pathology, Subharti, my alma mater, and I thank everybody from the core of my heart for giving me an opportunity to present. Thank you so much, Dr. Vijay Vadvan sir. Thank you, Dr. Vandana, Dr. Preeti, and Dr. Suhasini. Thank you so much.
Thank you so much, ma'am. Thank you.
Thank you. Thank you.